and today Dr. Rickey is going to be presenting an update on female stress urinary incontinence.
All right, great. So everybody, thanks for being here today. This is an update on stress urinary incontinence in women. We're going to be talking a little bit about just where the trends are going in terms of treatment, also going over some epidemiology and the latest evidence of comparative efficacy when it comes to different sling types. Okay, so these are my disclosures. We talked about the overview and what we're going to be talking about. So first I want to talk about prevalence. This is overall urinary incontinence by decade of life, just to review some epidemiology. You know, this is an older article from back in 2005, but actually it was one of the first epidemiologic studies that really looked at population rates of incontinence instead of just focusing on the clinical population that we're all used to seeing. So I have some boxes highlighted in red here. This is just to show you that overall, you can see by decade of life, starting with the 30s up till the 90s, that overall incontinence does increase. You can see that stress incontinence, which is the box on the right that's highlighted, is highest in the decades from the 30s to about the 60s. And then the reporting of the stress incontinence goes down, urgency incontinence goes up, as well as mixed incontinence. So this is another way to look at the prevalence of urinary incontinence. This is a more recent article using the NHANES data, and NHANES was an NIH-sponsored study that was, again, a very large population study that actually, incontinence just wasn't on the radar, you know, I would say before kind of the early 2000s in terms of chronic public health diseases that we should be looking at. So again, you can see here, looking at 2005 to 2012, sorry, I need to move myself over a little bit here. So overall incontinence is really at about 50% if you add those different lines up. The blue line at the top is stress incontinence, the gray is mixed, and the navy line is urgency. So again, you can see that, remember, this is like self-reported using standardized validated questionnaire. So you can see that stress incontinence peaks around the mid-30s to mid-60s and then goes down, while mixed incontinence and urgency incontinence trend upwards towards the 7th and 8th decades. So, as we can see in the previous slide, we have rates of overall incontinence increasing per decade of life. We know that the prevalence and severity of incontinence increases as people age. This is a forecast for incontinence in women. You know, the US population, the older segment is increasing, so we have a larger population segment of older Americans, and accordingly, the prevalence of incontinence has been forecasted to increase by about, I think it's like about 55%. So from about 18 million, and this is just, you know, those bars represent the upper and lower estimates. The middle, this was estimated using fertility rates and population estimates. So using that, estimated to increase from about 18 million in 2010 to about 38 million in 2050. So this is a real problem, and I'm going to talk about some prevention research at the end of the talk. I know that most of this talk today is about treatment. You know, we're surgeons, and the clinically affected people that have made it to our office are already bothered by their symptoms. They've been impacted, they're interfering, they have access, and they have the health literacy to sort of know that incontinence isn't just something to be expected as you get older, but something you can actually intervene about. So there's a lot of factors that actually get somebody into your office, and I will be focusing mostly on treatment today, but I think we have to understand that this is a problem. There's what's called a hidden burden of benign LUTs in men and women. And so I think there's a lot of work to do earlier in the trajectory before somebody ends up in our office. So let's talk a minute about trends in stress incontinence surgery. This is for the most part going to be slings. So just to orient you, the slide on the left, you're looking, and this is from 2000 to 2009. This is looking at overall procedures. The line in red are slings. The line in blue represents Burches. And then down at the bottom is periurethral bulking, the green dotted line. You know, mid-urethral slings really came on the market in the mid to late 90s, and then had really an uptake in utilization in the early to mid 2000s. And so those mid-urethral slings or the mesh slings is really what's driving up through 2009. There was an AUA study that came out in, or report that came out in the late 90s that really showed that slings and Burches were more effective than the needle suspension procedures. You'll hear about the RAS and the Pereira and some different needle suspensions. Those really went by the wayside after the mid to late 90s, based on some evidence-based reports that showed they really just were not effective as the sling and the Burch. There was another study that came out in 2005 that was the UITN study, which is an NIH-NIDDK urinary incontinence treatment network study that also showed that sling was more effective than Burch. What really happened though is to do a Burch, you have to make a fan and steel incision. You can do it laparoscopically, but still you have to, it's done from above, from an abdominal retropubic approach, whereas the mid-urethral slings, as you all know, can be done from a purely vaginal approach. And so I think that was also a factor. Just in terms of looking at the graph on the right, this is just showing each one of those different bars shows a different, this is showing that across the age, across the decades, which is the x-axis, each one of those lines represents a different year, 2000 to 2001, 2002, you know, to 2003. And really these trends are quite similar for when you look at the use of slings across age, and the average age of surgery for incontinence, for stress incontinence anyway, is around 51. This is just, this is a slide showing again the uptake in slings. One of the things to understand also is if you look at the light gray line at the bottom, that represents periurethral bulking or injections, you know, like it used to be the collagen back when, a contagen when collagen was made. Now there's a variety of substances that can be injected, but that line really has stayed quite flat. And I'll show you some graphs of some more recent data to support that. So you can see the age-adjusted rate of slings increased enormously from 2.36 to 9.45 per 10,000 population from 2001 to 2009, whereas the periurethral injection stayed about the same. And this has more of a niche population, and it's used a little bit more in older patients with some more comorbidities. Although it is sometimes used in younger patients who really feel like they can't take the time off for surgery and really want to have something that can be done in the office or a very quick in and out procedure. We'll go into periurethral bulking in a little more detail later on. So that takes us up to like 2009, 2010. So this is a recent 2020 publication that just came out in Urology. Una Lee out at Virginia Mason was the lead author, and this was part of the Urologic Diseases in America project that looks at large epidemiologic trends. So this used some private payer database analysis. This was all based on claims data, and they used, for the younger patients, they used Optum, and for patients 65 and older, they used CMS, which is Medicare and Medicaid reporting. So if I could just focus your attention on the top two blocks, you can see that there is, in this age group on the left, overall, you know, about 10% all the way up to 12% of women that were 18 to 64 years old with incontinence were getting sling procedures. And around 2009, 2010, you see that decrease. When you look at the box on the right-hand side, this is broken up in terms of ages. So the line at the bottom is the youngest age group, 18 to 24. I think anybody that does these kind of procedures knows that this isn't the most common population that we do these surgeries in. However, at the top, those lines represent the 35 to 45. And that's getting up to about, almost 15% of women with incontinence getting sling procedures, and then decreasing down to 10% by the end of 2013. The boxes on the bottom are demonstrating different regional, geographic, as well as race and ethnicity differences. And I think the reasons for this aren't very well understood, for some of the reasons I spoke about before, about the lack of sort of appreciation around social-ecological influences on both the development of symptoms and how people access care. So, but the highest rate of these sling procedures were in white women, followed by Hispanic, and then Black, and then Asian. So going to this next slide, this is now women that are 65 years and older. So the rates of slings in these procedures overall is lower. In the slide before, we saw 12 to 15%. Now we're seeing more in the, kind of 4 to 5% range. And again, you can see this real drastic drop once you get around in this age group. You can really see a nosedive that took place around 2010. When you look at the box over in the upper right corner in the red highlighted box, the highest rate is in the younger patients, 65 to 69, followed, and it kind of just goes in order of age. So, the residents and I talk about this when I give this lecture to them. And what happened, in this time was you had an uptick in sling uptake after mid-urethral slings. There was an FDA safety notification that occurred in 2011 that really was focused on vaginal mesh procedures for prolapse and the need for more safety and efficacy data. However, this really got conflated in the media with sling procedures, which were actually quite well studied and continue to be the best studied incontinence procedure we have, with a real accumulation of data demonstrating the safety and efficacy. However, because incontinence procedures are done so much more often, they represented the majority of the lawsuits. So, thank God for the lawyers protecting women and women's health. Lawsuits increased for sling procedures from about 700 in 2011 to 37,000 in 2013. I'm fairly certain it's not all just representative of an all of a sudden problem with the slings that occurred in 2011. So that's what we think anyway accounts for this drop in sling procedures that occurred over this time. And in fact, what I saw and what many saw during this time was not just a decrease in procedures, but also a decrease in people even coming in. The lawyers, the kind of legal society is, I'm about to blame, but they, I guess, took advantage of this. And then the media, actually, there were so many issues in the media with that FDA safety communication. I know I and others wrote many sort of letters to the authors and op-ed pieces trying to explain that this didn't affect slings, but unfortunately, it really scared a lot of people off from even coming in for treatment, for evaluation. So this is out of NYU, and so the x-axis, I apologize, it's a little bit hard to see probably on your small screens, but what they did was they looked at 2010 through 2017, and they broke it up in 6-month increments. So there is a little bit of up and down here just based on who, kind of upticks and changes in providers and their practice and how many women were actually coming in. But you can see here that there was an uptick in procedures in general for incontinence. And again, the yellow line is overall procedures. The blue line is mid-urethral slings. The gray line is bulking procedures, and then the orange line at the bottom is pubovaginal sling or fascial sling. So you can see what's really driving the changes here is the mid-urethral sling. So starting to go up, and then in 2011, immediately after the FDA safety notification came out about vaginal mesh procedures for prolapse, sling rates really came down too and reached a low in 2014. Now, whether or not this made a difference, it's certainly the timing looks reasonable, but an Aug Sufu position statement came out around that time where there were authors from both societies that put out like a one-page document that talked about the safety and efficacy of mid-urethral sling procedures, of the body of literature behind it. And you can see after this point, the sling procedures seem to rebound. The fascial sling procedures remained fairly flat. They did go up a little bit after that FDA safety notification, and probably overall they're done a little bit more than they were in the like around 2010, 2011. But this is just a viewpoint, but also from a single practice viewpoint, that there was a real change in practice patterns for several years after the FDA safety notification. So I'm going to get in, excuse me, now to some treatments. I'm going to briefly go over non-surgical treatments. I know the ones of us in the audience that do this a lot know about this, but I just want to make sure, you know, we're all urologists. We're all seeing men and women with lower urinary tract symptoms. We're all seeing, even if, you know, kind of partners and friends that might have some of these conditions. So I think it's important that we're advocates for all the different treatments that people can get in case we're asked about it. So just real quickly, in terms of behavioral treatment, you know, a lot of times we think of behavior as more related to urgency incontinence and overactive bladder. In fact, with stress incontinence, there was a very nice study out of UCSF with Leslie Subak where they looked at a structured weight loss program. This is in obese women. So this is not, you know, women with a, you know, BMI of 28 that want to get down to 25. This is really women in the obese range, that a weight loss of even 5 to 10% resulted in a 60% decrease in stress incontinence episode versus a 15% decrease in controls who were also obese, who got some bladder, you know, kind of bladder health, I guess you would say, education, but were not part of that structured weight loss program. So this was really pretty significant drop in incontinence episodes. We sometimes, in some of the literature looking at bariatric surgery, we see similar numbers. So there, I think the mechanism of action isn't very well understood. Sorry, but for sure, we can talk to patients about weight loss. Of course, that has a host of other good benefits for health in terms of reduction of diabetes, cardiovascular disease. So, you know, healthy behaviors tend to travel together and can have overall health benefits. I also tell patients, though, this is easier said than done. I don't demand some sort of weight loss before we consider surgery. But I do have some women coming into my office who have already lost some weight, and they really are motivated to see if they lose a little more, if it's going to affect their incontinence status. So I think this is some good evidence to give them. Pelvic floor muscle exercises too. I continue to be really sort of shocked by the lack of understanding in our primary care community and even amongst some urologists and gynecologists that this is actually very effective treatment for some women. I know people are saying Cochrane review in 2007, that was the first Cochrane review that came out that supported pelvic floor muscle training or strengthening as first-line treatment for women with incontinence. It actually works well for both stress and urgency incontinence. And these data have continued to be updated. I think the most recent one was 2017. There was a study that I would encourage people to read, especially residents or people that are thinking about going into either general urology or female pelvic medicine. This was a study that came out of the Netherlands. It was in the New England Journal in 2013. And in the Netherlands, there's actually, in most European countries, postpartum pelvic floor muscle training is just included for about a year after birth as a way to decrease the rates of the risk of incontinence progression. In the Netherlands, I think the reason that this study came about, it was actually mandated that women do a course of pelvic floor physical therapy or pelvic floor muscle strengthening before they were even allowed to get a sling. So a little similar to how many insurance companies require that women fail or have tried a few medications before they go on to third line therapies in overactive bladder like Botox or sacral neuromodulation. It's kind of a little bit of a more algorithmic approach to stress incontinence. So now this isn't the right fit for everybody though. That's gonna prolong effective treatment for some women. Some women do great with pelvic floor muscle therapy or strengthening, and some women get very little benefit. So they randomized women. Overall, there was greater objective and subjective cure in the surgical group, as you would expect. Surgery, the mid-urethral slings are very effective. And about 50% of the women in the pelvic floor muscle group ended up crossing over to surgery. They were allowed to cross over. So they did both kind of a intention to treat analysis for this study, as well as a what you actually got analysis. And one thing that I like to point out is that even though we know that slings are going to be overall more effective in a large group, about 30% of the pelvic floor muscle therapy only group reported improvement using the PGII, which is the Patient Global Impression of Improvement, which is a single item global response item used that's been validated for use in incontinence treatments. But 30% reported they were much better or very much better and were able to avoid surgery. So this is how I use this particular paper when I talk to my patients. I really am surprised. Some women just don't want to do it, and that's fine. I have some women who I truly don't think are going to get benefit out of it, but they want to try it. And I'm sometimes really surprised, whether it has to do with their age. I had a young woman recently who was in her 30s, and she was a runner, and you're sort of thinking, geez, how, that's like this pounding. Can you really build up the pelvic floor enough to withstand significant leakage during running that's requiring a pad? And she came back, I think 3 or 4 months later, and was super happy. She was barely leaking. She didn't need a pad anymore. So we have very poor predictive tools. And clearly my Gestalt is one of those poor predictive tools. So I think it's something you can't really assume that someone's not going to use a pessary or not going to use pelvic floor muscle therapy. And on the other hand, don't assume they're not a surgical candidate, for that active 85-year-old that wants a sling, that's healthy and not a lot of comorbidities. Don't deny her, that option either. So I like to offer all these treatments in all of my patients for the most part, of course, not a blanket statement, but within reason. The pessaries are also included as part of the counseling that should take place. This is part of the AUA guidelines in the treatment of SUI in women, which I encourage everybody to read. I think that as a quality indicator, that incontinence rings should be offered, and it should be documented in your note. I think that more of these quality indicators are going to start coming out in terms of if we get to a more value-based payer system. And they certainly, again, can be very effective in both young and old women. They're a good option for women that are in the middle of childbearing that have really bothersome incontinence, but they know they're going to have more children, and you really want to avoid doing a surgery in the vaginal area until they're done with childbearing. So this was a study where it was sort of a patient preference trial, and they let women choose what they wanted. About 2/3 chose a pessary trial to at least try it. Of the women that chose a pessary trial, many of them had successful fittings, meaning that the provider was able to find a pessary that was comfortable and that decreased their urine leakage, and about 50% were using it 6 months. So I want to draw your attention in that pessary picture to the pessaries at the top that have the knob. Those are the ones that can be used for incontinence. Some of them are used, in fact, for people that have a combination of prolapse and incontinence. We do use this intervention much more frequently in women with prolapse. There are a lot more data about the evidence in prolapse. It is highly effective. I would say my experience with incontinence is a little more heterogeneous. But again, some women are really motivated. They really don't want surgery. And for some women, this is highly effective in terms of improvement. In other women, it's not, it's more of like 50–60%, but again, it might be enough for them if they want to avoid surgery. And the picture at the bottom, just to orient you, this is someone laying down. So there's that pubic bone at the front, pubic symphysis, and then the coccyx at the back, and you can see the way this pessary is fitting. It's in this woman, she has a uterus, so it's seated behind the cervix, and then that knob sits right at the bladder neck. Really, all of our treatments for stress incontinence in the end provide some degree of bladder outlet obstruction, some relative degree of increased pressure around the bladder neck, whether that's using the pelvic floor muscles to increase the tone around the urethra, the pessary, which provides external compression, and the periurethral and sling, bulking and sling, that also provide compression. So just, this was a study that came out of the pelvic floor. This might have actually, no, I can't remember. So there's the Urinary Incontinence Treatment Network that was funded by the NIDDK, and then there's the Pelvic Floor Disorders Network, pelvic floor, which is funded by the NICHD. The Pelvic Floor Disorders Network is still in existence today and doing very high quality randomized surgical trials for prolapse and incontinence. The UITN was disbanded several years ago. So anyway, this was a study looking at pelvic floor muscle exercise versus pessary versus both. This is more just to demonstrate the efficacy of both of these, because they really didn't find an improvement when you combine them. Also, just to orient the group here for people that don't see this, these were not women that had like one leakage episode a week. You know, 50% had at least 14 episodes of leakage a week. So this was kind of a population that you would really maybe think about surgery in. And they had 8 weeks of in-office treatment or were randomized to pessary. You can see at 1 year, the rates of, again, using that PGII global response, that about 50–60% of patients reported they were much better or very much better. No bothersome SUI symptoms in about 2/3 of the group. And that's 75% reduction in incontinence episodes has been shown to correlate with high patient satisfaction. So you can see that this was in about 57% of both groups. So again, the thing we're lacking is predictive tools about who might really get benefit from this versus not. So unfortunately for right now, we're relegated to recommending a pessary trial where they come in and get fitted and try it for a few weeks. And if they like it, they can continue. And if not, then we go on to plan B, which is going to include surgical treatment in most of these women, if they're interested in therapy. So now we're going to move on to surgical treatment of incontinence. I'm going to spend a little bit of time on periurethral bulking, and by little I mean like one slide, and then the rest of the time we're going to talk about comparative efficacy and safety of slings. So periurethral bulking, this has been around for a long time. We used to really commonly use collagen, which was marketed by Bard under the brand name Contigen. Now there are a variety of different substances used that are synthetic instead of the collagen. There was some thought that the synthetic substances would be, since they were not absorbed, would be more efficacious. I don't really think this has been shown. This can be done in the office. It's sometimes really hard. You know, this is right at the area where I find that people are most sensitive during cystoscopies. And so then you're sticking a needle in, not just once, but 2 or 3 times. The female urethra in particular is short. It's sometimes difficult to get a purchase on this area. Some women tolerate it great, like they barely feel it. And for other women, it's a real challenge. And, you know, they are uncomfortable, you're sweating, sometimes feel like cursing. It can just, it starts bleeding. It's hard to see in a female urethra. So I don't know. You know, in my fellowship, we did a lot of these in the office. I think it kind of depends on the patient. It's a little more controlled in the OR. One of the things though that you kind of miss out on in the OR is in the office, you can have them cough. Their bladder's full because you're doing a cystoscopy, and you can put in more of your product right then and there if they're still leaking with cough, and you can have them stand up and cough also. You lose that ability in the OR. So you just have to know your patient. If they're have any kind of irritative or painy symptoms, maybe the younger women don't tolerate it as well as the older women. But you can see the results are pretty good. I find the results after this procedure to be a little more heterogeneous. The sling is a little more predictable for me and patient over patient. You can see about 50% of patients require a second injection to get to their dry state. There still can be retention, just like our sling procedures, but it only lasts like 2 or 3 days, so it tends to go away. So this is something, to be honest, I don't use a ton of in my practice. I think, again, you can see I'm not alone in that. When you look at those trends, you can see it's fairly flat over time, and I think it has its niche, either in maybe older women with comorbidities who can't undergo a surgical procedure, but I have sometimes other younger women. You know, I have a few patients that really have what I would consider ISD, a really kind of a crappy sphincter, and they really need a sling if they want success, and they really don't want a sling for a variety of reasons. And in those women with really poor sphincteric competency, they get like 2 weeks efficacy and then they come back. And I tell them, I'll do it a second time, I'm not doing it a third time. You run out of real estate in the female urethra. And although a history of periurethral bulking has not been shown to affect your sling outcomes, I still just get a little worried about injecting over and over again. There was one, also I would say that this, I think bulking used to be used more frequently in women without hypermobile urethras. The concept that a sling, there are data to suggest that women with non-hypermobile urethras, meaning when they cough, when you're examining them, you really don't see that deflection of the meatus upwards. And you might see this more in maybe nulliparous women that are presenting in their 60s or so with incontinence, that they might not do as well as with a sling because you don't get that kinking mechanism because there is no mobility of the anterior vaginal wall. I would say that while there is some data to suggest that sling procedures are less effective in women that do not have hypermobility, they are still very effective. And for me, I don't go to bulking just because they don't have a hypermobile urethra. That's not really a factor for me in deciding what procedure they're going to get. But others might disagree. So now on to our sling procedures. There is the retropubic mid-urethral sling or mesh sling. There is the transobturator or mesh sling. There is our fascial sling using a rectus fascia or fascia lata from the thigh. And then finally, kind of the newer kid on the block, these single incision slings where the sling is anchored into the obturator internus fascia, however, does not traverse this space, as you can see in the full transobturator sling just above. So real quick, just because we have more studies on outcomes for mid-urethral mesh slings than fascial slings, so I wanted to highlight one of the kind of real seminal studies in fascial sling. This was the study I referred to earlier. This was called the Sister trial, and this randomized women to fascial sling versus Burch urethropexy. This was 650 women. One thing to also note about this study is a lot of the studies, this came out in 2007, a lot of the studies before this, the outcomes had to do with maybe negative cough stress test at 12 months or different patient-reported outcomes, or really it was more about how the surgeon perceived the outcome. People were really shocked when these success rates came out, including the investigators, and a little dismayed that this was going to say, oh no, like we're not really trying to say that sling and Burches are only 66 or 50% effective, but they had a very strict composite score. This was like no leakage in 12 months, like you didn't leak a drop. So, as well as some other measures. So this really, I think, influenced the way we started reporting stress incontinence outcomes. And truly, now the way I talk to my patients with mid-urethral slings, which actually have similar outcomes, it's not, but you can see the treatment satisfaction is 86%. So how do you reconcile those two? Well, you can look at like almost cure, right? Like really you don't leak, like you are almost never leaking, if never. And those rates probably are around the 50th percentile. However, you have a lot of other women, 25, 30, 35% that are getting enough improvement that they are highly satisfied. You don't have to have somebody that goes from using 3 pads a day to, you know, if they're leaking once every other month, every now and then, they are still very happy. Like I said, that 75th percentile, that 75% improvement in incontinence episodes really seems to correlate well with treatment satisfaction. So you can see there was a difference in overall success as well as treatment satisfaction in Sling versus Burch. Of course, there were sling revisions required more frequently in pubovaginal slings. This is usually for bladder outlet obstruction, either leading to complete retention, maybe not super uncommon, but more of an incomplete emptying, voiding dysfunction picture. And then one of the things, when I was training, there was this real concern for de novo urgency incontinence in OAB, not just as an outcome as a de novo or new symptom, but also that you might worsen their pre-existing urgency incontinence. So there was a real reluctance to offer a sling to women with concomitant OAB or urgency symptoms. Now, one thing, and this has changed a little bit, I think there's pretty good acceptance that the pubovaginal or fascial sling has maybe a slightly different mechanism of action. I don't think anybody's quite sure, but there seems to be slightly greater rates of bladder outlet obstruction, voiding dysfunction, retention when you use a fascial sling versus a mid-urethral sling. So I definitely am not as reluctant. I'm going to show you some data also where they did mid-urethral slings in true mixed incontinence situations. So, but you can see even here, de novo urgency incontinence requiring treatment was quite low. It was 3% in both groups. And this has really been borne out moving forward into more contemporary studies. Oops, sorry. In terms of long-term outcomes, I say longer. Right now, just to let you guys know, for new incontinence and prolapse treatments, for efficacy, I would say most people want 3-year outcome data at the minimum, 24 months. I think safety data is okay, you know, to report at 6 to 12 months, but no one's really interested in 12 months. I mean, not interested, but you know, women don't want to know how they're going to be doing a year from now. They want to know how they're going to be doing 5, 10, 15, 20 years. And we unfortunately don't have that data. There are very few studies that went, you know, longer than 5 years. That UITN study that I told you about, there was an E-sister or extended trial where they were able to look at 5-year outcomes in about 75% of patients. You can see the continence rates really went down, though satisfaction remained high. So is this the natural history of incontinence? Is this an increase in overactive bladder? Is this just the sling changing? I don't know exactly. But the satisfaction, which was 86% in slings at 2 years, stayed high at 83%. You can also might have a bias of people that stay in the study, but nonetheless, I think it's still, we can agree it stays high. Retreatment, surgical retreatment was different in the two groups. It was 12% in Burch and only 2% in slings. And I would say this is sort of in the wheelhouse of what we see now in terms of surgical retreatment after sling surgeries. But we still really have a problem with long-term data that go, I mean, not a ton more than 2 years and very few that's really more than 5 years. So it's hard to counsel patients, you know, probably in any benign LUTS provider in the audience, you know, we have a really hard time counseling patients what, you know, a 50-year-old, what it's going to look like when they're 70. So this next trial was also carried out by the Urinary Incontinence Treatment Network, and there was another large randomized study done by another group, a multi-center group. This is just to show you retropubic, which is the REMUS, retropubic slings versus transobturator slings. And you can see in the top one at 24 months, again, using pretty strict success, they were similar in the 55 to 65% success range and very high satisfaction that was similar between groups. And another randomized control study with 1,870 women. Again, about 60% what we're saying dry and another 25% improved. Importantly, you know, this is not 100% success rate. It's not even 95% success rate. It's pretty consistently about 85% success, patient satisfaction. So you have to tell your patients that there is about a 10 to 15% chance they will not be satisfied with the procedure. I occasionally have women coming in that get almost no change. I mean, it's disappointing for both of us, but they all have a friend who had this amazing outcome after an outpatient surgery. And You have to just orient them that there's a chance that it might not be successful. You can see now this retreatment rate is not necessarily all surgery, but just retreatment in general. This could include bulking or sling release, pelvic floor muscle. You can see that the retreatment was actually a little bit higher in the retropubic group in the second study. That has not borne out in most other studies. But most people are very, very satisfied with this procedure. Again, longer term outcomes, ETOMUS, which was a longer term follow-up of that mid-urethral UITN procedure. So success rates dropped a little bit, which was no SUI symptoms and no retreatment was their definition. Satisfaction drops a little bit too, but still pretty good. And in another study that had 5-year follow-up, they had 95% with 5-year follow-up. They had about 85% with a negative cough stress test and pad test in the office and no retreatment, high satisfaction. This is just showing you the accumulation of data that really, even when that FDA safety notification came out, the first one back in 2007, most of us that were doing a lot of these procedures didn't blink really, because we knew that there were data supporting the safety and efficacy of the mesh slings. Nothing's perfect, and I think patients understand that, and there are some complications, but overall there are a lot of data to support their use. In terms of they all want to know, not just how long is it going to last, am I going to need additional treatment? And so in ETOMUS, the total rate of retreatment for incontinence was about 9%. The rate of actual surgery was less than that, maybe about 5%. There was also a study that looked at surgical retreatment amongst Medicare beneficiaries. It was about 7.5%. And finally, there was a very large study that came out from the UK. I believe this was reviewed in Journal Club, where they found overall 4.5 reoperation rate for incontinence over 9 years, and only about a 3 to 4% rate of sling removal revision for complications that could include either bladder outlet obstruction or mesh erosion. So I think these are all encouraging numbers. I think you can tell your patients somewhere in the 5 to 8% range risk of needing retreatment over a 10-year period. Of course, there are some women that, when I say fail immediately, they really never got success and they might need retreatment earlier. So finally, we're not going to really see a randomized study of fascial sling versus, sorry, I'm just making sure I'm not getting any notifications from you guys on my phone. But this was a study of 200 women where they were able to self-select pubovaginal sling versus mid-urethral sling, and they had pretty equal numbers in both groups, a few more in the mid-urethral sling. Of note, the mid-urethral sling group had more baseline urgency incontinence, and this probably reflects provider counseling patterns. As I mentioned before, there's sort of this fear of a little bit of an increased bladder outlet obstruction effect in the fascial slings, and we know that obstruction can lead to changes in the bladder structure that can lead to increased overactive bladder symptoms. So, but we can see that success, again, no subjective SUI and a negative cough stress test in the office is similar. Urgency, incontinence, persistent, resolution, de novo symptoms similar. Low rates of complications in both groups. Sling release was also low, and using a visual analog scale, the satisfaction was equal. So overall success rates are good in both. It really just, and I do offer patients both. However, I do a higher for sure. I have not done a fascial sling in a little bit. When you look at the practice patterns across the country, there are certain practices where there's higher rates of fascial slings, and that's fine. And there's actually some women that are specifically seeking out fascial slings, and that's fine also. It's just all the counseling, and I think we can be reassured though that the success rates are good in both with good safety profiles as well. So when I talk about mixed urinary incontinence, this has been a little bit of like a conundrum, for people that do this. On the one hand, we know that overall success rates are lower in women that have higher urgency symptoms at baseline. So you can see when success is defined as very satisfied. In a negative cough stress test, you have 60% in a mixed group versus 80% in a more pure, if you will, SUI group, although I would say those patients are not that common, so it's really stress predominant. There is overall increased risk of SUI failure, approximately double the amount. And subjective cure at 5 years is also reported as lower in a mixed UI group, 55%, versus about 80% in a more pure stress incontinence group. However, you often see a significant improvement in urgency symptoms in women with mixed incontinence. Now, I would not offer a sling necessarily to improve somebody's urgency symptoms. I think you really have to be doing it for their stress incontinence symptoms. You have to stress that the reason you're doing it is for stress incontinence, and that their overactive bladder symptoms may or may not get better, may require additional treatment, all that sort of thing that goes into our counseling. However, this ESTEEM trial, which was undertaken by the Pelvic Floor Disorders Network and recently published in JAMA, really, I mean, these were women with a real mixed picture. They really want to get at the root of, like, you have this woman sitting in front of you and you're actually kind of, you know, which way should I go? And they actually, when they looked at their overall population, had a significant improvement in all UI symptoms at 12 months, worsening urgency incontinence in about 3%. So this is women with baseline urgency symptoms. Now in this trial, what they actually did, they let everybody got a sling. So it was up to the provider or surgeon whether they got a retropubic or transobturator. They were randomized to getting an additional kind of pelvic floor muscle exercise / behavioral program. And they didn't show any change in the success of stress incontinence outcomes. However, the women that were in the pelvic floor muscle program were less likely to require additional treatment at 12 months. And that additional treatment, for the most part, like over 80%, was medication. So I think this suggests that it reduced the overactive bladder symptoms, the urgency incontinence symptoms, worked nicely in combination with the mid-urethral sling. So I think this is something to remember in your mixed group. Don't be afraid of women with mixed incontinence. I think what we really need from this study are predictors. This is a heterogeneous group, and some women do great and all of their symptoms improve. In other women, it only touches their stress symptoms and not their urgency incontinence symptoms. And you can see there's a few women who have worsening urgency incontinence. The reason we care about that is a major driver of dissatisfaction. So urgency incontinence in general has more interference. It's less predictable, more bothersome. So those women are really, really unhappy. So we need to do a little better job of figuring out who's at the highest risk for that. So just to kind of go over quickly some of the post-operative outcomes that everybody sort of fears and worries about. This is a compilation of some of the most recent data that we have. So again, I think we have pretty good evidence that in patients with mixed incontinence, the urgency component resolves or improves in about half. It's unchanged in about 30 to 40%, and it does worsen. I'd say the 15% is on the high side, but these are sort of the numbers I give just to set appropriate expectations. De novo urgency symptoms seem to be at most about 10%. This has been shown in several different studies. Voiding dysfunction, another major driver of patient dissatisfaction. This can mean many things in the literature. It can mean full out obstruction. Those are the easy ones. Sometimes it's just a change in flow, like hesitancy or incomplete emptying or intermittency. Sometimes it presents as really bothersome urgency, frequency, and even urgency incontinence. And really what you're trying to figure out in the early post-op period is this due to bladder outlet obstruction? If there is an immediate change that wasn't there before, I think you have to assume it's your surgery before anything else. But that being said, the overall revision rates are about 1.5 to 3% for bladder outlet obstruction. Even though these numbers are low, you can see the really significant difference in satisfaction. As opposed to 80 or 90% that would recommend, only about 45% will recommend, and there's a high dissatisfaction rate. Unfortunately, I keep harping on our predictive tools being kind of poor. It is difficult to predict. I think in someone that has pre-op voiding difficulty or Valsalva voiding, that's sort of easy. But Otherwise, the urodynamic parameters, pressure flow studies in women are notoriously difficult to predict because a lot of women void at much lower pressures than men. And even in an obstructed woman, that pediatric Q max might be like 10, not like 40 like we might see in men. So, but some other risk factors are prior incontinence procedures. Women get older, this gets a little bit more likely. Concomitant surgery, interestingly, can go either way. Having a concomitant prolapse procedure may increase your risk or decrease your risk. So this is definitely an area that needs greater study. Mesh exposure, I would say it really is pretty uncommon. I counsel my patients about 5%. Certainly for me, smoking seems to be the biggest risk factor. I do have some women with diabetes. Sometimes we use the hemoglobin A1C as a surrogate for healing, and might be a little reluctant to do this in somebody with poorly controlled diabetes. But otherwise it's low and usually fairly easy to take care of. Pain is one of the things that we really fear the most. You can see in my last bullet, I think this is more common in those seeking litigation. Overall, post-op pain after slings is uncommon. I mean, more than 6 weeks. But one of the major risk factors is preoperative pain. I know people might be going like, yeah, duh, of course it is. But the problem is you got to look for it. I ask about sexual activity in all my patients, and especially in surgical patients, I'm really looking for dyspareunia. A sling procedure or prolapse procedure is not going to fix dyspareunia in the vast amount of patients. This can have a multifactorial etiology, but if you got to look for sort of a chronic pain history, fibromyalgia, look for myofascial tenderness in the pelvic floor muscles and the retropubic spaces. These can all just be little flags. I'm not saying you're not going to do a procedure in that patient, but you might give it a little bit of a second thought, and you have to be very, very careful about counseling them and documenting them that their pain could get worse, that this is not going to fix their pain, they have baseline pain. I'm very, very careful in these patients. And I try to sometimes treat their pain ahead of time if it is equally as bothersome. For some women, it's as easy as, using some transvaginal estrogen cream. Other women have more musculoskeletal kind of problems, and I end up sending them to pelvic floor physical therapy to try to treat their myofascial pain before we move on to the incontinence component. Finally, I'm going to end with single incision slings. They're called single incision because it doesn't come through the retropubic space or the transobturator space. So there's just the incision in the anterior vaginal wall. These got a really bad rap when the initial generation came out because they weren't really anchored in anything. They had very poor success rates. So there was a Cochrane review that came out that included TVT Secure, which was the main driver of these terrible rates. And when there's one study that I'm aware of that compares it to a retropubic sling. I didn't include it because it did show a pretty big difference between the success rates, and also the outcomes that they reported for the single incision slings really don't match up with most contemporary experiences. So at least compared to a transobturator sling, I think we're getting pretty good data that suggests that they are fairly equivalent. In this systematic review, there was a quote unquote trend towards more repeat incontinence surgery with the single incision sling, although the confidence interval included 1, so this was not statistically significant. When we look at, there's actually some nice 3-year data that came out. This was just published in 2020. And this was actually the bottom one was the Boston Scientific 522, the 3-year outcome data required by the FDA. They had 75% with 3 years follow-up. Subjective success using that PGII was good. During their 3-year time period, they had 1 reoperation, and dyspareunia and pain was low. In the upper study, you can see, again, these have a lot of women. Women with ISD or really poor sphincteric competency were excluded. It has been shown that in women with ISD, that the retropubic slings are really superior to transobturator. So again, good outcomes. I will say that at least the white study at the bottom, these are industry-sponsored studies, so hopefully we'll see more non-industry sponsored studies. Sometimes the outcomes tend to change, but I think overall we're accumulating good data that single incision slings are safe and efficacious as well. I'm going to end in the last few minutes with sort of future directions. You know, cell-based therapy has been looked at using not embryonic stem cells, because there are some ethical issues around that, but using autologous derived muscle cells. And in this one study, they are using using a needle biopsy from the vastus lateralis, part of the quadricep muscles. And so these can be, they have potential to form into different kinds of cells. So these cells can actually proliferate to form myoblasts, which then progress into myotubules and new muscle tissue. And there's also evidence that they may act by reconstitution of nerve and vascular cells. So this is kind of cool. I tell my patients right now, we can't fix your sphincter, but I'm hopeful that we can at some point. There was a dose-finding study in 80 women. Interestingly, you do not see results right away as you do with bulking procedures. And this probably has to do with the way that the stem cells work in terms of formation and reconstitution of muscle, nerve, and vascular cells. So, you know, they had 93% of their patients with 12-month follow-up. There was about 3/4 that had greater than 50% reduction in leaks, and about 50 to 60% with an increased reduction, with 50% reduction in their 24-hour pad test. There was a recent clinical trial that randomized women to cell injection versus placebo. It was halted early because the placebo rate was really high. And so they're sort of rethinking the way that they designed the study. So, but I think that that's something to look for that's really quite exciting. Last but not least, I would be remiss if I didn't say a few words about prevention, given that this has funded my research for the last 5 years, and we just found out this week that we've been refunded for the next 5 years. So that's really exciting news for myself and for the department. So just for those of you that don't know, this is the Prevention of Lower Urinary Tract Symptoms. It's a multi-center study funded by the NIH. Our goal is to establish the evidence base for future primary and secondary prevention intervention studies. It is a transdisciplinary group. I like to say the clinicians are the least important, which isn't completely true, but we make up just a small proportion of the members. This is really, our focus is to take a public health lens and a social ecological perspective. I think not just in benign urology, but in cancer, you know, we have been so focused on the far right, the individual, and not just the individual, but genetic and kind of biologic factors, clinical factors, and are just starting to look at other things like behaviors, health literacy, psychosocial factors. And then when you expand out towards the left, where does that person live? You know, that bladder is not just like walking around in a vacuum. They're inside a person that lives inside a house, that lives inside a community, that lives inside a society. So, you know, Marianne and I wrote a SUI prevention paper earlier this year. And just as an example, you know, you'll note in my picture here, I have some young girls and women, and that's because, like most chronic diseases, there are probably factors that start in childhood and adolescence that increase one's risk over a lifetime for lower urinary tract symptoms. So, you know, we just haven't been asking this age group, but it's been shown that about 1/3 of high school and college female athletes report SUI. This is not just during the sport, this is during their daily life. And not only that, young women that engage in high impact sports have a higher risk of SUI as they move through adulthood. So there's probably something about pelvic floor effects that happen early on. We know that sexual activity is associated with UTIs, which is also, so these are just some examples, also associated with an increased risk of LUTS overall. Sexual activity in the adolescence and how this relates to UTIs and LUTS has not been very well looked at. And finally, we know that there are psychologic stressors that are associated with overactive bladder, and there are traumatic childhood events as well as probably more chronic stressors, such as your kind of your neighborhood, your food safety, just different things that also can affect your overall health as well as your lower urinary tract symptoms. So we have not done a good job of looking at this, but we are doing it in the PLUS network. And our goal, you can see over here at the left, like, as I said at the beginning of the talk, current research and clinical efforts have really focused on the so-called tip of the iceberg, if you will. These are people showing up with symptoms in our office. However, as you move kind of on this trajectory of an increased proportion of the population, there are some women who have been evaluated who have these symptoms, some people that are seeking, who have these symptoms that are seeking care, but there's a whole lot of women that have symptoms that are not presenting for treatment. We know this even in very bothered women, only about 50% present for treatment. And we really don't have enough data on people with very early symptoms. So our plus prevention strategy, which you can see on the right, as we move into the future where we can affect a far larger proportion of the population, is focused on identifying risk and protective factors so that we can implement prevention strategies and benefit the entire population. So sorry, I went a minute over. And I guess I didn't do a very good job of leaving time for questions, but I guess if it's if there's people that are on that don't have to leave right away that have questions, I'd be happy to take them.
Dr. Rickey, we do have one in the chat. ISD data, which treatment and which sling?
For ISD, so just for people that don't do this day in and day out, that stands for intrinsic sphincteric deficiency. That has some traditional urodynamic parameter definitions. That is a abdominal leak point pressure or leak point pressure less than 60 and a maximum urethral closure pressure of less than 20. Those are very strict numbers. I will say, I mean, how many urodynamics do I do? And I see MUCPs of less than 20 very infrequently. So I think we can use numbers that are a little bit higher. Sorry, I was just looking at a text from Adam. But so yeah, so those are the numbers. And so I my go-to is a retropubic sling. I'll be honest, I don't do a lot of transobturators. So, but in that population, I think you for sure want to do a retropubic sling. I think you could do it either with a mid-urethral or a pubovaginal. In my practice, I tend to save pubovaginals for secondary or tertiary procedures. We don't have a good algorithm for this. There's no evidence base to support that, but I guess I just like moving a little bit from a more minimally invasive to a more maximally invasive to increase my ability to retreat if I need to, even though that, you know, the chance of needing retreatment with another sling is relatively low as best we understand. But I would for sure do a retropubic in ISD. And even, you know, some of my colleagues and partners that do a lot of transobturator and single incision slings, and somebody with certain urodynamic parameters that suggest ISD, they will do a retropubic sling.
Dr. Rickey, I have somebody in chat that said they sent a question directly to you.
Oh yeah, I see one from Rosoff, which, yeah. James, do you want me just to shoot you a text or answer?
Yeah, that would be great.
Shoot you a text?
Yes.
Sure, no problem.
Thank you.
Yeah, no problem. Asking about if there's any kind of medicines that can help. All right.
Thanks, Leslie.
Yep, no problem. Thanks everyone for getting up and listening.